those of you that don't know me, my name's Megan. I'm one of the PTs here. We're going to talk a little bit about arthritis today. So just a little overview. We're just going to go over some anatomy, talk about what arthritis itself is, talk about pain with arthritis, ways to help that pain, what are the benefits of exercise, and then any additional treatment or evaluation that you may need if pain kind of persists. So first we want to just talk about your joint surface anatomy. This is where your arthritis is occurring. So all your joint surfaces have this articular hialine cartilage. So that functions to bear and distribute loads on the joint, and it reduces friction between the joint itself. This is self-lubricating, so when a pressure is applied, it kind of releases some fluid to kind of give your joint some lubrication, which helps surfaces glide together and move well with each other. Now, stiffness can, that's my computer making noise. Now, stiffness can decrease that load distribution and kind of alter it to where we're not getting that fluid appropriately, or it's causing pressure at different points. And that reduced loading then can lead to degenerative changes. And then those degenerative changes means there's less cartilage, so that means less chance for that fluid to kind of move around in the joints. So I'm going to go through a couple of major joints that arthritis typically presents in. We'll just go through some anatomy, talk about bone structure, major muscle groups, ligaments, and the joint surfaces itself. So your shoulder is a common point of arthritis. Bone-wise, we talked about the scapula, clavicle, and humerus all coming together. Big muscles in this are, we think of rotator cuff and deltoid, but there's a lot of accessory muscles around that shoulder joint as well. We're looking at teres major, your lats, your pecs, your traps, rhomboids, serratus, and biceps. And those kind of all can surround shoulder joint itself, upper arm, and in the front of shoulder, so they're all kind of coming together. Your rotator cuff and your deltoid specifically are kind of working in this forced couple, so they're used to specifically lift your arm overhead and kind of do functional things that you're doing every day. Ligament-wise, we have ligaments that surround your ball of your humerus that sits in the joint. So over top, in the middle, and below your glenohumeral ligaments, your acromioclavicular ligament that kind of comes across here. A small coracoacromial ligament kind of comes across the front, and then those two coracoid and your acromion, which are pieces of your scapular bone attached to each other with another ligament. And then at the joint surface itself, we now have that articular cartilage. You have a labrum that kind of acts to cushion that joint itself and sits in the joint and cushions where the ball attaches. And then bursa sacs that kind of just give some cushion where your tendons and ligaments are gliding. Your hip, another big source for arthritis. So from a bone structure, we have your femur meeting your pelvis, that ball going into the socket. Major muscle-wise, we're talking about our glutes. Those are our big stabilizers for the hip. Your iliopsoas is your hip flexor. Your rectus femoris comes down the front. And then hamstrings, your adductors, and these tiny little external rotators that kind of move your leg in and out. Sit like really deep near the joint. And then we have some ligaments that kind of attach bone to pelvis, so iliofemoral, pubofemoral, ischiofemoral, and your ligamentum teres. From the joint surface itself, yes, Laura?
When you get arthritis in your hip, is it always the same location?
Yes, so any arthritis is going to come from joint surface itself. It's not going to come from those muscles around it, but what can happen, and what a lot of times is happening, is that load distribution, right? So we're weak muscle-wise, so we're kind of altering body mechanics, which then alters how we're loading that joint. And I have some stuff later in the presentation, but just like factors that can kind of play in, like age, weight, all of that stuff can kind of contribute. So it's coming from a multitude of sources, but yes, the arthritis itself is going to be at the joint joint level, in most cases, yeah. And then from the hip standpoint, we're talking about that articular cartilage again. You also have a labrum in your hip, and then again, bursa sacs to kind of act as cushion between those tendons.
So, not related to arthritis, but if somebody falls and fractures their hip, is it in that same spot, or can it be in different
Not
spots?
always. A lot of times people either fracture, so right up in here, where this like neck of your femur is, a lot of times when people will fracture here, you'll have like a line across here where that fracture is, or a lot of times they'll fracture really high up on this femur bone, so they have to put rods and screws in here. The complication with this is when we see like you fell and say you were maybe arthritic already, or you fell maybe in your early 50s and then we're talking 10, 20 years later and now arthritis is a problem at the joint. It depends on where they put their hardware, that it can be a little tricky on replacing a joint at that point. So that can definitely be a little bit of an extra layer of complication. You see it a lot more with hips and sometimes shoulders if people have humerus fractures. That again, like depending on where they fracture that humerus, it can also cause some issues with hardware if a joint replacement is needed. Because what they do when they do a joint replacement is they basically like drill in and they have to find good blood supply for the prosthetic piece to fit in. So it's like wood shop. So they have to kind of like hammer into that bone until they find that good blood supply, because putting that piece in, new bone has to kind of form to stabilize that. So they need blood supply to kind of help build that bone back. So running into hardware issues close to that joint can be problematic. So it does get a little tricky for both shoulder and hip. You don't see it a lot with knees, but if people have like lower leg fractures, or if their femur fracture was low, it could, but I would say more often than not, you're seeing it more with hips and shoulders.
So when somebody falls and fractures their hip, is it usually then a hip replacement, or not always?
It definitely depends on age, and status of joints from the get-go, on what they're going to decide. Again, it also depends on where in the leg that it happened too, because if it's like middle of your femur bone, then okay, we're going to put some plates and screws. It's probably not going to be an issue later if we need to do a hip replacement. But if we're talking up here and you already have an arthritic hip, yeah, likely they're going to probably just do a replacement, because what are the chances you're going to need that replacement again in a couple of years anyways? So why not just do it all at once? And hip replacements are really easy recoveries for the most part. People feel really pretty good within a month or two. Knees can be a little longer, but hips usually do pretty well in terms of
Hips are
recovery
much easier.
process. Yes, yeah, you feel better way quicker. And then going on to the knee, we're talking bone-wise, femur down distally, your tibia and fibula below the knee, and then your patella, which is your kneecap. Major muscle groups, your quads, hamstrings, and your gastroc, which is your calf muscle. Ligament-wise, we have our ACL, PCL, MCL, LCL, so we're stabilizing for backward movement, side to side. And then your quad tendon goes into patellar tendon across the top of the knee. Again, we're looking at articular cartilage and then a medial lateral meniscus to kind of give that cushion on both sides of the knee, and bursa sacs. And usually when you're talking arthritis-wise from this, you're seeing it here for the most part, or where these meniscus are kind of breaking down, or if you have a previous injury, that can be an issue too from a knee. Like a lot of people, if they tore their ACL when they were younger, or had any sort of meniscal injury, a lot of times when they do meniscus surgery, they don't typically repair it in a lot of circumstances, because it takes a lot to repair it, and there's a lot more restriction post-operatively on weight bearing. So a lot of times, if it's just a tiny little tear on one part of that meniscus, they'll just shave it down and kind of make it nice and smooth again. But then that makes you more at risk for arthritis issues, because now we've lost lost some of that cushion that we're then like functionally doing stuff with over time. And again, this could be meniscus issue when you were 20 or meniscus issue when you're 50, but again, you're going to still have those same issues. And then the ankle. So not always something that people think of first off the bat, but ankle arthritis is common and replacements are becoming more common as well. Bone structure wise, your tibia and fibula distally, a talus which kind of sits right here, and then your calcaneus, which is that lower heel bone. Muscle group wise, we have your gastroc and soleus, those are your calf muscles, your perineals, which sit on the outside of the ankle, your posterior tibialis, which goes on the inside of the ankle and comes across your arch, kind of helps lift that arch up, and then your tibialis anterior, that is your shin muscle. Ligament-wise, we're talking Achilles, and then laterally on the outside, we have an anterior talofibular ligament, your calcaneofibular ligament, and posterior talofibular ligament, and those work on stabilizing if you go to bring your foot in this way. They kind of reduce that force, which ankle sprains, a lot of times that's what you're seeing. Those ligaments are the issue. And then your deltoid ligament sits on the inside of the ankle and works on stabilizing against an outward force.
The recovery from that is
Ankle sprain?
replacement.
People do pretty well. It's
You have to be non-weight bearing, because I tell my friend at the surgeon, they're coming in on their little scooters.
yes, most times yes, for a period of time. And it depends on how much they have to do. Ankles definitely can be tricky because sometimes they're doing some stuff with Achilles too, because your Achilles tends to get like tight and shortened up a little bit. So a lot of times they'll lengthen that, which can add to time of non-weight bearing. And just depending on how much they have to do from like a bone standpoint can play in with that as well. It's not common like with other joint replacements, where like hips and knees, like your walking day one, you are restricted usually about like 4 to 6 weeks on weight bearing. My dad has had both done, and he was more restricted the first time around, and they had to do a lot more work. The second time, I think it was 4 weeks when he was allowed to start weight bearing. Now they'll start doing like non-weight bearing stuff in PT before that period of time when you're weight bearing, but just to like get you moving and less stiff. But yeah, there is a period of time that you do have to be non-weight bearing, and to be able to navigate a scooter as well. So it adds in a little extra layer. And then our back. Arthritis can happen there as well. We're talking vertebrae, and then all the way at the end, your sacrum, which kind of connects to that pelvis. Muscle-wise, your erector spinae and your lats are more superficial, and then deeper, we have our quadratus lumborum, your multifidi, and your rotators. Big ligaments, anterior and posterior longitudinal ligaments kind of sit across the spine, your ligamentum flavum, and then deep ligaments, but kind of around those joints itself, between like the little pieces that kind of stick out of the spine. Supraspinous, interspinous ligaments, intertransverse ligaments, and iliolumbar ligaments. And then again, we have cartilage, and in this case, we have these intervertebral discs. So, can you guys see this?
Mm-hmm.
Let me see if I turn off the lights. Is that better? A little bit. So discs are like jelly donuts. They give you cushion this way, but you can have some like degeneration of that disc itself. So there's some less like cushion and shock absorption between, but also you can have arthritic changes at these joints on the side, so kind of where those bones stick out on the side and meet together. So it can cause issues from both respects. Now the tricky part with the spine and where you get your degeneration at is that there's nerves that run really close through those spinal canals. So if there's less space, because we're now degenerating, it can cause some pressure on the nerves, or if the disc is now a little less springy, it can cause some issues and push like kind of one way or the other and put some pressure on that nerve. A lot of times that's when you're going to see some like symptoms into your legs. And a lot of times that's pain or numbness and tingling. Any of that can kind of occur together with that issue. Now, that's not to say that you can't just have a disc issue itself, completely separate from arthritis. And again, that disc kind of pressing on that nerve can cause some issues, both with back pain and leg pain.
It's not to do with her, but what about a bulging disc?
So that's what I'm saying. So a lot of times that can happen because we did something with poor body mechanics, or we weren't using good core activation, that kind of stuff. And bulging discs are not permanent. The thought is like, oh, well, I had a bulging disc 25 years ago. Okay, it's still there. It's not in most cases. So discs are cool. They can kind of reabsorb back to where they centrally need to be. And then if you do that in conjunction with PT, we're putting you in movements that kind of facilitate that movement back centrally. So it relieves that pressure on the nerve. It kind of gives you that cushion back to where it needs to be, rather than kind of dispersing these loads in weird directions. Okay, so now what's arthritis? Inflammation, stiffness of the joints that may result in pain due to loss of cartilage cushion between the surfaces. So there's no specific cause that can pinpoint, but it can be often linked to age, joint injury, overuse, obesity, and genetics. As we talked about, all these joints that we just hit on are big places for arthritis. Hips, knees, shoulders, back, hands and wrists can be another place. And studies have actually found that over half of adults will develop arthritis at some point in their lives. Now, that can be found on imaging. Even in a 30-year-old, they may find some issues. But it's the fact of like, are we symptomatic? Because that's when we need to address like strength, further interventions, that kind of stuff. Now, symptoms with arthritis typically are some sort of pain, stiffness, or loss of range of motion. Swelling can kind of happen just because of how those loads are distributed and the joint gets irritated. You can be tender to palpation. Any like buckling or giving way can happen as well. And that, a lot of times you'll see that buckling giving way with more like knee issues. But that is tricky because that can also be linked to meniscus issues too. So it's kind of the pulling the pieces out of what is causing pain, what are symptoms like, that kind of stuff. And then they do, a lot of times we'll do x-rays to determine like, is it arthritis or is it something else more like soft tissue structure wise. So now we're going to talk about like, when are we continuing activity versus are we changing it because our pain is significant enough. So regular arthritis pain, typically you're going to see that worse in the mornings, or after you've been more sedentary, those initial steps or that first little bit after you've been in one place. It often improves with movement, but the catch-22 is that you're in pain and then you don't want to move, right? So it can also be worse in the evenings too if you've had a busy day or after you've done all of your activity. A lot of times people will say, oh, I lay down at night and then I notice my pain, right? And then clicking can happen, but clicking itself is not concerning. We don't worry about that unless that clicking is accompanied by sharp pain. If that is the case, a lot of times we're talking about meniscus, labrum, some sort of ligament issue that we need to figure out what's going on, because pushing through that with pain can cause some issues that should be kind of nipped in the bud as quickly as possible so we don't cause further injury. Now, pain that should limit activity. Again, sharp pain. Pain that doesn't go away with rest or like modalities of some sort, ice, heat, over-the-counter medications, that kind of stuff. And any pain, this is kind of a personal, like this is what I recommend to people. If your baseline pain, whatever that is, if it's going more than a 2 to 3 out of 10 above what your baseline is, then I would stop what you're doing. And if your baseline is sitting at a 5, 6, 7, then I think we need to alter stuff to begin with before we even start thinking about activity. So how do we help kind of mitigate this progression of arthritis? Exercise. We want to strengthen muscles, using good body mechanics when we're lifting, a healthy lifestyle, including diet, weight loss, and controlling blood sugar. High glucose levels can kind of contribute to that breakdown of cartilage at the joint. So diabetes or anything like borderline can cause some issues with arthritis as well. Now, what are the benefits of exercise? You can improve strength, range of motion and mobility, joint lubrication because we're moving those joints, so again, not self-loading, decreased pain, and improved balance and stability. Now, what are we going to focus on exercise-wise? Range of motion, because a lot of times you're losing that range of motion to some degree, so you want to keep those joints as mobile as possible. And prevent stiffness, because back to that stiffness means decreased loading, that can kind of contribute to further progression of arthritis. And there's really no way to know like how quickly is arthritis going to progress once you have it. But again, these things can kind of help slow that progression and keep that joint supported and stable. From a strengthening standpoint, for the lower extremity, we're going to focus on hip, knee, ankle, and your core and balance. Upper extremity, shoulder, elbow, and stabilizer muscles kind of around your scapula. So we're talking back here between your shoulder blades. Those are weak in most people, and especially if you worked or work a desk job. We're sitting at a desk all day in this position, and things get weak in the back. So a lot of times we're working on that postural strengthening to kind of help support the shoulder. And then just any stretching, because muscles can get tight and stiff, so we want to kind of keep those as limber as possible just for improved mobility. Now, when do we want to talk about seeking more care if exercise has not worked? At this point, if we're having severe pain, if your pain is not consistent and not improving, if your movement and strength training are not helping to improve your symptoms. Now, we're not looking overnight. This is going to take, if you go physiologically from a start of a true like exercise strength regimen, your body needs at a minimum 6 to 8 weeks to kind of start showing true strength gains. Now, depending on how weak you were to start, those strength gains may improve and show significant improvement, but they also may not be as strong as you need to be. So you may need more than that 6 to 8 weeks to really gain the strength that you need to kind of support that joint. Any worsening stiffness or limited mobility of the joint, and functional deficits. Are we having issues walking, doing your daily tasks, that kind of stuff. So if you go to ortho, what are they going to typically do? A lot of times they'll do a physical exam, and x-rays are pretty common in the office, especially if you're telling them you're having these symptoms that are pretty indicative of arthritis. Occasionally, and depending on how your symptoms are, if you have exhausted other conservative methods, or they've done x-rays and they're not really giving them an answer, they can do an MRI. This is typically kind of a last resort after conservative measures have been exhausted, because one, they're expensive, and two, MRIs typically are done with the purpose of finding out what's wrong because we probably need surgery. So unless that is the end goal, then there's not necessarily a reason to do an MRI. Now, treatment-wise, we're looking at ice or heat. With arthritis, it's probably been going on for a while, so it's not like we recommend one over the other. A lot of times people have a preference, or they like certain things at certain times of day. If you're stiff in the morning, sometimes that heat will help to kind of just loosen up the joint, relax those muscles. If you've done exercise or you're a little bit sore at the end of the day after increased activity, sometimes ice is better because it'll cut down on that little bit of inflammation that can happen just from kind of doing stuff. Medication-wise, over the counter, we're talking about NSAIDs, ibuprofen, Motrin, that kind of stuff, or acetaminophen, Tylenol. Topical patches, lidocaine, Salon Pause, there's a Voltaren patch or a gel that people use, and that's kind of person to person dependent. Some people like it, some people are like, I didn't get any relief from it. And then if your pain is severe enough and none of this other stuff is working, occasionally they will prescribe opioids, but this is obviously very controlled and they're not just gonna give it to everyone that walks through the door. To decrease load, assistive devices can be helpful. Canes, walkers, that kind of stuff. And then it's possible for them to do injections as well, and that's often a next step if you're having this chronic pain, things aren't getting better, it's still bothering you, you've tried exercise, what have you. So there's two types of injections they typically do. Steroid injections are usually first round of what they're trying, and occasionally, and often, they'll do multiple rounds of steroid injections. They have to be separated by a certain period of time. I think it's at least a minimum of 3 months between injections, but it may be longer. I'm not positive on that. And then the other option, and sometimes they'll do this after they do steroid injections if the steroids didn't really do much, or if they're having more lingering pain, is a hyaluronic acid injection. So these are the gel shots, chicken shots. Euflexa is the brand name for what they commonly use, and that basically just gives you some extra cushion in that joint where you're lacking some of it.
So when I had my hip injection, I had to go to, when they did it with an x-ray machine. Which one is that?
A lot of times they do it with an ultrasound, right?
I don't know, I just know the doctor. I had to go to the hospital and they did it.
Yeah, so they'll usually do x-ray ultrasound guided injections. That was probably a steroid, but they may do it with the Euflexa too. But basically that's for them to just know we're getting that in the joints, right, where it needs to be, because one, from a hip standpoint, your joint is really deep in there below muscle structures, so they need to know where is that going. I think that hips definitely most common that they use, and lumbar a lot of times, that they use the imaging with it. Knees, I don't think they typically use imaging with those because it's so superficial they can palpate and figure out where they need to be, but it's more just for accuracy on where they're putting it. And then again, if all of this has failed, and we're talking, okay, surgery, joint replacement, that kind of stuff. So surgical options vary per joint. Your knee, there is a partial and a total knee replacement. Partials definitely are not as common. You see them typically in younger populations, if people are having arthritis issues in their 40s, 50s, because joint replacements only have a certain lifetime. So there's a possibility if they do an early total joint replacement that then they're going to have to go in and redo it at some point, and that could be 15, 20 years down the line. So if you think, I had this at 50, now we're at 70, we're needing another one, health status changes, all of that. So there are some things that can play in with it, so they want to kind of mitigate that as long as possible. Hip, you're looking at a total hip replacement. Shoulder, there's a total and a reverse total shoulder. Typically, nowadays, you're seeing a lot more reverse than regular total shoulder replacements. And what they do with that is ball and socket sit like this normally in a shoulder, they flip it. So this is your socket, this is your ball. And the reason being is because most times when people are having arthritic issues with shoulders, they're older and they've done stuff with their arms their whole life to function. And people a lot of times have chronic rotator cuff tears that they didn't know they had, or that they had issues with, they didn't get a repair, that kind of stuff. And if that is the case, they don't have good tissue for that rotator cuff to be attached, so it won't function to lift your arm and do stuff after a total replacement. So they have to flip that ball and socket, which means that then your deltoid muscles kind of overtake the rotator cuff function. people do really well with it. The only like change is that you don't quite get like full overhead. You might be here, you're very close, that people are not noticing like significant functional limitations. The other precaution early on after surgery from a reverse total shoulder is they don't want you reaching behind and up or across the back, because there's more risk for dislocation. So there's some precautions with that. The hip replacements, there's also some precautions depending on what way they go in. So old school, they used to do everything from the back, and that came with hip precautions. So you weren't able to cross your legs, you weren't able to bend your knee up towards your chest super far, that kind of stuff. But now, a lot of newer surgeons and some of the older surgeons that have kind of come with the research have done more of an anterior approach. They've gone through the front, they're cutting through less muscle, and there's not precautions. You're able to do whatever you want, within reason, right away after surgery. So recovery is a little better, and people are less fearful because everyone's so worried about dislocating with those precautions if they go in from the back. And then ankle, they can do a fusion, which is what they were doing for many, many, many years. And then now, recently, there's been this move to total ankle replacements, and people are doing very well with them. And then lumbar-wise, typically they're going to do a fusion to kind of stabilize you. So they put rods and screws in there and kind of lock those joints in, so there's not so much movement. The tricky part with fusions, from an ankle or a lumbar standpoint, is if you're locked in place, then above or below or both have to take on more load. So a lot of times you'll see, especially with a lumbar fusion, if they're fusing you at 1 or 2 levels, then the levels above are taking on that load, and you have issues down the line that they may have to go in and extend that fusion. So that's why a lot of people are very cautious with lumbar surgery, because it can lead to, okay, now I'm going in multiple times for more surgeries because I'm having issues further up the chain. Questions? Yes?
Actually, I have 3. Does a lot of movement make more loss of cartilage, or does everything do it?
No, so movement is good because we're lubricating that joint as best as possible. Now, if we're not strong, can that movement, if we're doing like poor body mechanics or kind of altering how we're loading that joint, can it contribute a little bit? Maybe, but it's not going to significantly progress your arthritis in any way, shape, or form. So arthritis is kind of going to progress how it's going to progress. So if you can move and it's manageable, then the more movement, the better.
Okay. And then when you put the picture of the knee on, it looked like it was like everything on the front. What about the back of the knee? If you've got pain in the back, is that arthritis or something else?
So a lot of times that's muscular. I would say most people with arthritis pain in the knee, they're seeing more like inside outside or like front. Not to say that you can't have some back, like posterior knee pain, but I would say a lot of times that's coming from a muscle standpoint, because your hamstrings come through your calf's coming through, and then you have a lot of tiny little muscles that kind of come through the back of the knee. There's also cysts that can develop. It's called a Baker's cyst. So it's like basically a little pocket of fluid, and that happens in the back of the knee sometimes, that it can cause some irritation, and those, they just like pop a needle in there and drain it, and you feel a lot better. So if that's the case, those are usually a pretty easy fix. They can come back though, so sometimes they have to drain them multiple times, but most of the time I'd say like posterior knee pain is either muscular or cyst related.
Is heat the best thing for that thing?
It depends again, like if you feel like one thing over the other works better, then I'd say go for it. The only time I say don't use heat is if, okay, you say you hurt yourself yesterday and now we're in like really high pain or having trouble moving, we're probably really inflamed. So although your heat is probably not going super deep, it's gonna go deep enough that it may cause some extra inflammation. So we don't want to cause extra inflammation in that area that's already irritated. So I usually tell people to wait like a good, at least like 4 weeks or so from injury, if there was like a specific injury, to use heat. Otherwise, use whatever feels best.
Okay. And the last question is arthritis, does it come gradually or can you get it all of a sudden?
I would say typically it's gradually, but that's not to say that like you could have like aches and pains that you weren't necessarily paying attention to, that it was there, but then all of a sudden you're noticing it more, right? So, and typically it, like as it progresses is when you're gonna notice it more because you have less of that cushion, right? So, people will notice like when they're doing their daily tasks, when they're climbing stairs, when they're walking, that if it's from a lower extremity standpoint, or with a shoulder, like reaching overhead, that kind of stuff. So it definitely can like come on more gradually, you just may not notice it because it's not bothering you at the time. And you kind of write it off as, oh, I did something wrong, something like that, yeah.
Thank you.
You didn't really talk about arthritis in the hands. Any hints for that or any?
To be honest, I'm not the expert in hands. OT sees hands for the most part. And it's definitely possible. They can do fusions or joint replacements in the fingers as well. I don't know how common they are. Again, it's kind of a weird niche of hand surgeons and occupational therapists typically see that body part the most, so I'm not an expert on that. Anyone else? No? Good? Alright. Thank you for coming. Following up on this, we are going to do a workshop, probably separated by some body parts later in the spring or summer. So those are on the docket, and then we're probably going to do a class for exercise and stuff. The workshops are going to include some exercise, but then like a full 5 or 6 week class, probably in the late summer, early fall. So those are all on the docket. All right, guys, thank you for coming.
Thank you.